My name is Rick Hecht. I'm the research director at the Osher Center. I'm filling in for Shelley Adler, who couldn't make it today. Today is my pleasure to introduce someone who I think a lot of you will know already, Dr. Jennifer Felder. Dr. Felder is a licensed clinical psychologist who is dedicated to providing mental health during pregnancy and the postpartum period. She's assistant professor in the Department of Psychiatry and Behavioral Sciences, and is really a key research core faculty member at the UCSF Osher Center for Integrative Health. Her research focuses on treatments to improve sleep and prevent depression. In her research, she optimizes, evaluates, and disseminates non-pharmacologic interventions with an emphasis on mindfulness and acceptance-based approaches. She's committed to increasing access to evidence-based interventions, particularly among populations disproportionately affected by poor health outcomes. Her research incorporates innovative and equity-based formats for disseminating interventions, such as digital, co-located, and integrated services. In her clinical work, Dr. Felder provides cognitive behavioral therapy for insomnia for adults with chronic insomnia. After Dr. Felder's presentation, we're going to have about 15 minutes for discussion. Please submit any questions you might have to me by using the chat feature at any time during the presentation. And you can also pose questions directly to Dr. Felder during the discussion. I'd also like to thank our Grand Rounds Planning Committee that includes Dr. Selena Chan, Anand Dharuva, and Patty Moran, as well as Jen Shea, Yvette Coulter, and Julia Burns, who really helped make sure this functions well. Please join me in welcoming Dr. Felder.
Good morning, everyone. I'm so honored and excited to be here today to tell you about my research that focuses on promoting mental health during pregnancy and early parenting. For over a decade, I've studied mindfulness-based interventions for depression. And through this research, I started to become interested in the ways that sleep problems may trigger depression among mothers. So over the last several years, I've studied the consequences of sleep problems like insomnia and studied treatments to improve sleep during pregnancy and early parenting. Behind much of my work is the really strong belief that we can have really precise and robust interventions that are frankly irrelevant from a public health standpoint if we can't get them to the people who need them. And so I'm also dedicated to expanding access to mental health care. Most of the research I'll discuss today investigates using digital platforms like apps, websites, and video conferencing in order to expand access to these interventions. But first, I want to start just by acknowledging my mentors and collaborators and my lab members and funders who have made this work possible. I want to start by sharing a few things that make pregnant and postpartum women such a captivating population for me. During pregnancy and postpartum, there are unique opportunities for improving mental health. Pregnant and postpartum people have frequent contact with healthcare providers, so there are multiple opportunities to screen for problems like depression and insomnia. This is a time when women may be highly motivated to engage in behaviors and interventions that may promote their health or the health of their baby. I'm just noticing, it seems like someone else may be advancing my slide. I don't know if it's someone who has co-hosting capabilities. Sure, there's a way to stop that. This is also a time when women may be highly motivated to engage in interventions that promote their own health and their baby's health. And effective interventions can have intergenerational impacts, as shown by our UCSF colleagues, Amanda Nerone-Joe, Nikki Bush, and Alyssa Apple. But there's also unique challenges. Pregnant and lactating people are often excluded from clinical trials, which makes it really challenging for these patients and for their clinicians to make informed decisions about treatment options. As a result, many have concerns about pharmacological treatments due to limited data on their safety and efficacy. And many pregnant people and postpartum people report that mental illness stigma and perceived failure to live up to the motherhood ideal is a really powerful barrier to seeking mental health care. Pregnant and postpartum people also have competing demands on their time and energy, fatigue during pregnancy, childbirth and newborn prep classes to attend, and then sleep deprivation and intensive caregiving in the postpartum period. As you know, or as you may know, perinatal depression is a common problem. Perinatal is a word that you'll hear me say frequently. This means during pregnancy or the postpartum period. Approximately 12% of perinatal women experience depression. In addition to being a common problem, perinatal depression is also a consequential problem. My work and that of others has shown that perinatal depression is associated with adverse birth outcomes like preterm birth. It's associated with increased risk of suicide, impairments in parenting, and increases psychological disorders for offspring. Untreated perinatal depression has societal costs totaling billions of dollars annually due to productivity loss, increased use of welfare and Medicaid services, and higher healthcare expenditures. In light of these high personal and societal costs I just described, my research asks, can we prevent depression? Mindfulness-based cognitive therapy, so this question, can we prevent depression, led me to pursue graduate training with Sona Demijian at University of Colorado Boulder. She was studying mindfulness-based cognitive therapy to prevent depression. MBCT was designed to target the automatic thought patterns like rumination that trigger depressive relapse among people with histories of depression. MBCT targets these thought patterns through an integration of mindfulness meditation with cognitive behavioral therapy. Participants learn formal meditation practices like sitting meditation and body scan. They learn informal practices like mindfulness of daily activities and movement practices like mindful walking and yoga. Participants learn to identify their personal warning signs that depression may be returning, and they develop an action plan to respond skillfully before warning signs spiral into a full-blown depressive relapse. The intervention is delivered in a group format, which can increase motivation and accountability. It can also be a really validating and destigmatizing experience to hear that other of your experiences are shared by others. It's offered in 8 weekly 2.5-hour sessions. What's so exciting to me about MBCT is that meta-analytic work now shows that this 8-week mindfulness program outperforms antidepressants at preventing depression in non-perinatal populations. That is, MBCT is more effective at preventing depression than antidepressants. Over the last 15 or so years, I've contributed to several MBCT projects, including the Staying Well study, which adapted MBCT for pregnant women, Mindful Mood Balance, which adapted MBCT to be delivered digitally, MMB for Moms, which pilot tested the Mindful Mood Balance program in pregnant women, and now optimizing MBCT maintenance, or the OM project, in which we're pilot testing booster classes to extend the benefits of MBCT. I'll give a quick summary of each of these projects now. The Staying Well study was led by Sona Demijian and Cheryl Goodman with the goal of studying the efficacy of MBCT for preventing depression, specifically during pregnancy and the postpartum period. Our early developmental work suggested that we first needed to tailor MBCT for this population. So specifically, we learned that fatigue, low energy, and lack of time got in the way of completing longer meditation practices. And so we emphasized brief informal practices. It was also evident that self-criticism was a really strong theme among these pregnant women at risk for becoming depressed. And so we incorporated loving kindness meditation practices to focus on directing positive attention to oneself and one's baby. We provided psychoeducation about perinatal depression and anxiety. And because data on risk for perinatal depression highlights the role of low social support and isolation, we also focus on skills designed to enhance social support. Next, we pilot tested this tailored MBCT program in 86 pregnant women who were randomized to MBCT or treatment as usual. We followed these participants through 6 months postpartum. We found that 50% of participants randomized to usual care became depressed by 6 months postpartum, relative to 18 participants who were randomized to MBCT. So this is quite a large magnitude of an effect. But although MBCT was associated with significant benefit, we also saw that there were practical barriers to participation. So for example, the distance to the clinics where MBCT was offered, time conflicts with when MBCT was offered, these were the most common reasons that women declined to participate. In order to increase access to MBCT more generally, we developed a digital adaptation called Mindful Mood Balance. This work was led by Sona Demijian and Zindel Siegel. The content of Mindful Mood Balance is the same as standard MBCT, but instead of delivering the intervention in a group format, it's delivered digitally using experiential learning and video-based vicarious learning. In a randomized trial, participants who received Mindful Mood Balance evidenced mood benefits measured in multiple different ways. So they evidenced greater reductions in depressive symptom severity, higher rates of depressive remission, and lower rates of relapse compared to those randomized to usual care. Next, I pilot tested this program, Mindful Mood Balance, in a sample of 37 pregnant women with histories of depression. So they entered the study not depressed, but they were at high risk for becoming depressed because they had histories of depression. At the time, we were the first group to examine a digital program to prevent depression in pregnant women. And our focus was on evaluating feasibility and acceptability. But we were also pleased that we had encouraging preliminary findings showing that these women who were at risk for becoming depressed, who entered the study with minimal depressive symptoms, did not worsen over the course of the study. In exit interviews, participants reported experiencing benefit in the domains MBCT is designed to target. The majority reported that it helped them take action on early warning signs, gave them an increased sense of control over depression, and helps them relate differently to negative thoughts and emotions. You guys, I'm so sorry. I don't know why my slides are auto advancing, but bear with me. Hopefully it's not too distracting. Now at the Oster Center, I am so excited to be collaborating with this fantastic team to develop a program designed to maintain the benefits of MBCT. So although we know that MBCT is effective at preventing depression, these effects don't last forever. One study found that half of MBCT participants do experience a relapse within 2 years. Sally Adler and Chelsea Seawick conducted focus groups with MBCT graduates and teachers to understand the additional support that's needed upon ending the 8-week MBCT course. Here are a couple illustrative examples from MBCT graduates. Things didn't stick necessarily, so if you got a major stressor, it wasn't an instinct yet. It was not part of your marrow of how to react. It was easy to go back to the old ways of reacting to things. Another said, having some kind of support or some kind of consistency is the only way, for me at least, for it to work. We used this feedback to develop a 4-week MBCT booster course, which we're now pilot testing. This work is very much in progress, so I don't have results to present, but stay tuned. Hopefully in the next couple years, Rick, Hector, I will have exciting findings to present. One thing that became clear to me during this work is that depression is a really hard word for pregnant and postpartum people. When we gauge public attitudes towards pregnant and postpartum people, we see really extreme depictions. On one hand, mothers are expected to be happy and glowing with perfect hair and makeup, a fun mom boss even when they have a young infant and 2 young children. Or historically, women who are at the other end of the spectrum in terms of mood are thought to be dangerous and bad. Fortunately, I do think the media discourse about depression and pregnancy and postpartum has shifted over the last years, with more celebrities telling their stories. Nevertheless, numerous studies show that stigma is a barrier to seeking treatment for depression during pregnancy and the postpartum period. And so this has led me to wonder, are there less stigmatized inroads for promoting mental health? And one thing that I kept hearing over and over from my research participants and from my therapy patients was that their depression was triggered by the sleep disturbances they had while they were pregnant or by sleep deprivation in the postpartum period. Now, for those of you who have been pregnant, you may know the feeling of being super exhausted, like you desperately need sleep, only to find that sleep is totally elusive when you try to get it. Might feel impossible to get in a comfortable position, or your mind is busy thinking about everything on your to-do list, or you've got to go to the bathroom a million times a night. A sizable subset of pregnant people experience a more severe form of sleep disturbance called insomnia disorder. This is defined as having difficulty falling or staying asleep, despite having the opportunity to do so, resulting in significant impairment or distress. Increasingly, evidence backs up what my pregnant participants and patients were telling me. Insomnia is a risk factor for depression in both non-perinatal and perinatal people. And it's also common. Over 1/3 of pregnant people experience elevated insomnia symptoms. Insomnia is not just a problem for mental health, but it can also impact birth outcomes. My work with Eric Prather and our colleagues in the UCSF Preterm Birth Initiative showed that insomnia during pregnancy is associated with increased risk of preterm birth. In this propensity-matched sample derived from a cohort of nearly 3 million people in California, insomnia diagnosis was associated with increased odds of preterm birth. So focusing here on this row, this shows that about 11% of women without a sleep disorder gave birth prematurely, compared to 14% of those with an insomnia diagnosis during pregnancy, corresponding with a 30% higher risk. This paper received some media attention, and some of the reader comments on these popular press articles really help underscore the importance of this problem. It's frustrating that preterm birth is so poorly understood, and that most factors from stress to insomnia, both of which are probably connected, are ignored by doctors. I had terrible insomnia during my pregnancy, and my OB suggested taking Benadryl, but wasn't concerned because, as the article points out, poor sleep is common during pregnancy. I went into spontaneous preterm labor at about 28 weeks. My son passed away when he was 1 week old. I had what doctors told me was a healthy pregnancy, and my son was healthy, except that he was born too soon. As you can imagine, one of the most common questions people had for me after our insomnia and preterm birth paper came out was, is there anything that pregnant people can do to improve their sleep? Since then, my lab has focused on two conceptualizations for prenatal sleep disturbances. These sleep disturbances have different sources and therefore require different interventions. The first is what I'd consider standard insomnia, which just happens to occur during pregnancy. If I had a magic wand and could make this patient's pregnancy symptoms disappear, like the discomfort and frequent trips to the bathroom, it wouldn't matter. They would still have insomnia. The second is what I've come to understand as having pregnancy-specific factors that lead to poor sleep quality. Focusing first on standard insomnia that happens to occur during pregnancy. According to Spielman's model of insomnia, precipitating factors like stress, role transitions, hormonal changes can trigger an acute sleep disturbance. Some people respond to these acute sleep disturbances with totally understandable but counterproductive efforts to cope. Sorry, guys. So counterproductive efforts to cope could include spending more time in bed, increasing caffeine consumption, doing less during the day. While totally relatable, these behaviors can associate the bed with wakefulness and anxiety and decrease homeostatic sleep drive, which prolong the sleep problem. They may also develop dysfunctional or unhelpful beliefs about sleep. So for example, many of my patients with insomnia have a belief, something like, I have to get 8 hours of sleep in order to function. You can imagine how someone who has this belief might spend a lot of time in bed trying to hit those magical 8 hours of sleep, inadvertently associating the bed with being awake or with anxiety about sleep. When unable to get 8 hours, they may do less during the day. Maybe they exercise less, cancel plans, take naps, drink more coffee, all of which can decrease the drive for sleep. Holding a belief like this very tightly can also increase anxiety about sleep, thereby making it more elusive. Taken together, these responses can turn an acute sleep disturbance into insomnia. Cognitive behavioral therapy for insomnia was designed to target these counterproductive efforts to cope and unhelpful beliefs about sleep. Just a quick overview of cognitive behavioral therapy for insomnia, or CBTI. There are 5 treatment components. For many people with insomnia, the bed becomes a place of dread and anxiety, and so stimulus control is designed to reassociate the bed with sleep. Patients are instructed to only use the bed for sleep. If unable to sleep, get out of bed and do something relaxing or enjoyable until sleepiness returns. Time in bed restriction entails temporarily limiting the amount of time one spends in bed, which can lead to increased sleepiness and therefore help consolidate sleep by increasing sleep drive. Cognitive therapy involves identifying and changing unhelpful beliefs about sleep. Relaxation teaches practice for decreasing cognitive and physiological arousal before bed. And sleep hygiene promotes higher quality sleep by optimizing the environmental, physiological, and behavioral factors affecting sleep quality. CBTI has a strong evidence base in non-perinatal populations in both its standard in-person format and via digital apps like Sleepio and Somrest. Accordingly, the American College of Physicians now recommends it as a first-line treatment for insomnia. Not surprisingly, it's preferred by pregnant people relative to pharmacotherapy. But until recently, it was unknown whether CBTI is effective in pregnancy. And this is the focus on my research on an expecting moms and sleep therapy study, or the REST study, funded by the UCSF Preterm Birth Initiative. This was a question I truly had clinical equipoise about, meaning I wasn't sure whether we would be able to improve prenatal insomnia with this standard treatment, because there are so many factors that disturb sleep in pregnancy, like discomfort and having to use the bathroom, that we wouldn't be able to eliminate with CBTI. And so in the REST study, we predicted that pregnant participants randomized to digital CBTI would have improved insomnia outcomes relative to those randomized to treatment as usual. In today's talk, I'll focus on the rates of insomnia remission, defined as ISI scores below 8. Because research in non-perinatal populations also showed that the digital CBTI intervention was associated with improved depressive symptoms, we hypothesized that participants randomized to digital CBTI would have improved depressive outcomes relative to those randomized to treatment as usual. And today's talk, I'll focus on the rates of probable depression, defined as EPDS scores greater than or equal to 13. We recruited participants for the REST study via social media and the UCSF electronic health record. We included adult participants up to 28 weeks pregnant with probable insomnia disorder or elevated symptom severity and who had regular access to the internet. Participants completed a multi-step screening process, including completing an online screening survey, online sleep diaries for a week, and an online orientation to the study. Eligible and interested participants completed baseline measures and were randomized to either digital CBTI or treatment as usual, both of which I'll tell you about in a moment. Participants completed online surveys at 6 follow-up time points through 6 months postpartum. The intervention group received digital CBTI, specifically Big Health Sleepio program, which had been shown to be effective for insomnia in non-pregnant populations. The content is similar to standard CBTI. It's delivered in 6 weekly 20-minute sessions and is fully online, so participants could access it anytime and complete the sessions at the time and location that was convenient for them. And they receive reinforcement contingent on their progress. Participants who were randomized to treatment as usual had no limits placed on receiving non-study treatments, and they received digital CBTI upon completing the study at 6 months postpartum. In the REST study, over 2,000 people completed our screening survey. We ultimately randomized 208 to digital CBTI or treatment as usual, and retention was high at our follow-up time points. On average, participants were in their early 30s, and the largest proportion was white and non-Hispanic. More participants who were randomized to treatment as usual were pregnant for the first time, but adjusting for this didn't change any of our study findings. In the REST study, we found that the digital CBTI app, Sleepio, was effective for treating prenatal insomnia. This graph shows rates of remission from insomnia, so higher bars are better. We found that 10 weeks after starting the intervention, digital CBTI participants had higher rates of insomnia remission compared to treatment as usual participants. This was also true 18 weeks after treatment started and at 6 months postpartum. This work shows that prenatal insomnia is treatable, and it converged with evidence from Rachel Manber's lab and from David Kalmbach's lab, also showing that CBTI is effective during pregnancy. Now, here's the really exciting thing to me. We found that participants who were randomized to digital CBTI had significantly lower rates of elevated depression at 3 months postpartum. Even more striking, these depression prevention effects were strongest among the subset of participants who started the study with minimal depressive symptoms, which is similar to what's been shown in other labs with non-perinatal populations. For example, at 3 months postpartum, nearly 20% of these participants who were randomized to treatment as usual had probable major depression, compared to 0 of the participants who were randomized to digital CBTI. To highlight the significance of this figure depicts the point prevalence rates of minor and major depression across pregnancy and the first year postpartum. The highest point prevalence is at 3 months postpartum. In the REST study, we found that a brief, convenient, scalable intervention for insomnia delivered during pregnancy was associated with lower rates of probable depression at this vulnerable time point of 3 months postpartum. Although exciting, these results were preliminary. And now with my R01 from NIMH, we're conducting a confirmatory efficacy trial designed to provide definitive evidence about whether treating prenatal insomnia prevents depression. Over the next few years, we'll randomize nearly 500 pregnant people with insomnia disorder to digital CBTI or to a digital control condition, and follow participants until their babies are 1 year old, and focusing on depression incidence as our primary outcome. This idea that improving sleep can help maternal mental health has really picked up steam lately. So late last year, for example, the Washington Post published an article about prescribing sleep to postpartum mothers in order to prevent depression. The author provided really concrete recommendations, most of which boil down to enlisting the support of others to help with nighttime caregiving. In terms of related questions I plan to investigate in the near future, Lauren Asarno and I have just submitted an NIMH R01 application to follow these PRISM study mothers and their children until they're 3 years old. We proposed to examine whether this insomnia intervention delivered to mothers during pregnancy may also improve the social emotional outcomes of their babies. So I've just finished telling you about how we've used CBTI to improve insomnia symptoms in pregnancy and potentially prevent depression. But there were some limitations of this program, which have generated new scientific questions for me. Specifically, although CBTI outperformed treatment as usual, many participants didn't experience a remission in insomnia symptoms. And in exit surveys, participants attributed this to the fact that CBTI didn't address the pregnancy-specific factors that affect sleep. So, for example, I'm going to call your attention just to this middle comment box. One participant said, I found as I had more trouble sleeping, virtually all of it was related to pregnancy symptoms, like back pain in my second trimester, the need for more pillows, not being able to sleep on my back as usual, having to go to the bathroom 3 to 4 times a night. Another participant said, I would have liked for it to be more geared towards pregnant women tips for better sleep. CBTI was for the general public, and many points weren't relevant to me because I don't often wake up feeling stressed. I wake up uncomfortable. This feedback led me to develop another conceptualization for sleep problems during pregnancy, which has been the focus of my career development award from NCCIH. For many pregnant women, their sleep is disturbed by physical symptoms, such as difficulty getting in a comfortable position, hip and back pain, having to go to the bathroom frequently. Research in non-pregnant populations shows that the way that one responds to symptoms like these can increase arousal further, making it harder to return to sleep. Although it may be difficult to eliminate these totally normal symptoms of pregnancy, these psychological responses offer modifiable targets to improve sleep. I theorize that mindfulness and acceptance-based approaches may be particularly well suited for this problem. That is helping women learn skills for observing their symptoms, observing unpleasant sensations without as much of the cognitive and emotional reactivity to them may help them fall asleep quicker. In non-pregnant populations, these approaches are shown to help coping with pain, improving sleep in the context of pain, and improving insomnia symptoms. With funding from NCCIH, I launched the RISE study, which aimed to study the feasibility and acceptability of a mindfulness-based program for improving sleep quality during pregnancy. We enrolled pregnant women with poor sleep quality. Participants were randomized to mindfulness-based stress reduction, or MBSR, plus prenatal sleep classes, or to treatment as usual. Mindfulness-based stress reduction aims to relieve suffering and promote well-being, originally designed to help adults who are coping with chronic pain. Like MBCT, it includes formal and informal mindfulness practices and is offered in 8 weekly 2.5-hour group sessions. There were a few reasons that we chose MBSR as an intervention that might have potential for improving sleep during pregnancy. First, we had data from a daily diary study showing that the way that pregnant women respond to their nightly physical symptoms affected their sleep quality. So, for example, we found that there were certain responses to symptoms, like feeling annoyed or bothered by them, that were associated with worse sleep quality. But there were also responses, like being kind to oneself and simply observing their symptoms, that were associated with improved sleep quality. And these are precisely the types of responses that mindfulness-based interventions like MBSR are designed to cultivate. We also felt that MBSR would be a good fit for this population based on others' data showing that MBSR improves responses to physical symptoms and it improves sleep. And our qualitative data showed pregnant people were really interested in learning about mindfulness tools to improve their sleep. Several additional data points led us to also develop the prenatal sleep classes to complement MBSR. In our qualitative work, pregnant people told us it was impossible to find trustworthy information about sleep during pregnancy and the postpartum period. So in these classes, we provided sleep education. Our prior work showed that pregnant people with poor sleep quality, even without insomnia, demonstrate maladaptive sleep behaviors like spending an excessive time in bed awake. And so in our prenatal sleep classes, we taught stimulus control techniques to associate the bed with sleep. Our prior work also showed that sleep fragmentation was really common in this population. And so we also taught time in bed restriction. Finally, in our qualitative work, participants were eager for brief tools, middle of the night tools that they could use for coping with sleep disturbances. So our prenatal sleep classes taught brief mindfulness practices to cope with these. These classes drew from Nancy Bartyke's mindfulness-based childbirth and parenting program and Jason Ong's mindfulness-based therapy for insomnia program, and also benefited from the guidance of Rachel Manber and Judy Cuneo. We recruited participants mainly via Facebook ads. Participants were in their second trimester of pregnancy when the classes started, with poor sleep quality and who had regular access to the internet. Participants completed a multi-step screening process and were randomized to either MBSR or treatment as usual. The MBSR program was delivered via Zoom through the UCSF Osher Center in heterogeneous groups of men and women across the lifespan. In 8 weekly 2.5-hour sessions. Our prenatal sleep sessions were also delivered by Zoom in homogeneous groups, just of our pregnant participants who had poor sleep quality, in 8 weekly 30-minute sessions. Next, I have some slides that we used in these prenatal sleep classes. I thought I would share with you just to give you a little flavor of what the prenatal sleep classes were like. So first, we drew from MBSR and MBCT to present the 3 components of pain or discomfort. First, there's the sensory component, so the actual physical sensation of pain. Is it sharp or dull, pulsing, electric? We related this to the body scan practice that participants learned in MBSR, in which they learned to pay attention to the sensory component of discomfort or pain. Then there's the cognitive component, so how you think about the pain. Maybe you might have thoughts like, this is never going to stop, I can't bear this. Finally, there's the emotional component, so how you feel about the pain. So one might have thoughts like, I'm afraid of this, or I'm worried. We related this to sleep during pregnancy. So sleep is often disrupted by normal pregnancy discomforts. We can't eliminate these discomforts, but we can change how we respond to these discomforts. We presented mindfulness as a way of focusing on the physical sensations decoupled from the cognitive and the emotional parts. We shared with participants that our research shows that pregnant people who respond to these discomforts by feeling annoyed or bothered slept worse. And we invited participants to share ways that they responded to nightly discomforts that they noticed made their sleep worse or made their sleep better. We offered alternatives for coping with pain and discomfort, drawing from the brief practices offered in the MBCT program. One was counting breaths. Another one that participants really seemed to like was to allow an image of baby to arise in their mind's eye when having difficulty sleeping. We also taught the behavioral skills of CBT for insomnia, but from a mindfulness and acceptance lens, really drawing heavily from the guidance of Rachel Manber. That is, participants learned to cultivate an awareness of when their current state suggests that sleep is unlikely, and develop an acceptance of being awake instead of striving for sleep, and to get out of bed and do something relaxing or enjoyable until physical sensations of sleepiness returned. We related how these cognitive and emotional responses relate to sleep during the postpartum period too, by offering the following example. Let's say it's the middle of the night, you're fast asleep, suddenly you hear your infant fussing, that's the cause of your wake up. And let's imagine some thoughts you might have, like, I won't be able to sleep without, I won't be able to function without more sleep. Can't believe he's awake again. If you had those thoughts, what feelings might you have? Maybe frustration or overwhelm. We invited participants to consider other options. Same scenario, fast asleep, your infant starts fussing. This time you first pause, observe your infant, and then decide how to respond. So maybe you might think it's normal for infants to wake up in the middle of the night. Or let's see if he soothes himself back to sleep. Or I wonder if he's hungry or needs a diaper change. What kinds of feelings might you have then? Maybe calm, neutral, curious. So this helps illustrate to participants that the way that we respond to these wake-ups can have a big impact on how we feel and how quickly we may be able to return to sleep. In the RISE study, we assessed 715 people for eligibility. 52 participants were randomized. On average, participants were in their early 30s. About half were white and non-Hispanic. And in short, we surpassed all of our acceptability targets, including the percent of participants who initiated treatment and satisfaction scores. When we looked at the reason that people dropped out of the intervention, they didn't appear to be specific to the intervention. It was scheduling conflicts or other personal reasons. We also surpassed our feasibility target. Many of you know that recruitment for clinical trials is often a major challenge. So it's particularly encouraging that we exceeded our enrollment target 2 months ahead of schedule, and we observed high retention. I'm going to skip this in the interest of time and just get to a quote that I think really highlights or exemplifies what we hope to achieve with this intervention. In short, our preliminary efficacy data looked really promising. This participant said, even though I'm still woken up by my symptoms, my relationship to those symptoms has changed. I've been taught many ways to cope with those awakenings. While my sleep is not perfect, I do think without the education and tools I received as a result of this study, I would be having far worse time with my sleep. Some nights I'm experiencing disrupted sleep where I'm actually able to feel well rested the next day due to the techniques I've been taught with MBSR and prenatal sleep. Now that we've demonstrated the feasibility and acceptability of this intervention, we've submitted an R01 application to NCCIH to study the efficacy for improving prenatal sleep. So in conclusion, some things I would like to leave you with. We all know sleep is a pillar of health. I often hear from the women that I work with that their sleep problems are dismissed. They hear things like, oh, it's normal not to sleep well during pregnancy. If you think this is bad, just wait until you're waking up every 2 hours with a newborn. But we've all experienced the ramifications of low quality sleep. It affects how we feel emotionally. It affects how we parent and relate to our loved ones. It affects our exercise, our food choices, our productivity at work, and so on. More and more, my research and that of others shows that the consequences of poor sleep during pregnancy and the postpartum period are too great to ignore. In general, my hope is that my body of research helps us progress beyond simplistic, but all too common approaches to sleep problems during pregnancy, like the one that you see here in this cartoon. Sleep when your baby sleeps sounds great until you're faced with the reality that babies sleep at inconvenient times and locations, and it's actually really hard for an adult to entrain their circadian clock to an infant's. Now, we've shown CBTI is effective for treating insomnia, and it might also prevent depression during the postpartum period. We've also shown that a mindfulness-based approach has promise for improving pregnancy-specific poor sleep quality. Sleep disturbance may be a low stigma target for promoting mental health during pregnancy and early parenting, and the scalability of the interventions that I study increases their potential public health impact for mothers and their families. In particular, the emphasis of mindfulness-based programs on promoting mental health versus restoring mental health makes them particularly well suited for this population and for this problem. With that, I'll end. Thank you.
Thanks, Jen. That was great. Just a reminder, if you have questions right now, you can either send them to me and I can help ask them, or you can unmute and ask them yourself. I want to start with a question, Jen. So I think one of the things that's striking in the data that you have is the effect of the CBTI intervention on depression postpartum. So that's really months after you've really done the intervention. I think one of the questions there is, how much do you think that's due to what people are learning about sleep versus how much is that due to other skills they might be learning as well? Do you have any data or any thoughts on that?
That is such a great question. I don't have data on that, but my hypothesis is that by improving their sleep, we're also improving their ability to regulate their emotions. So there's less sort of like emotional reactivity to stressors, and that thereby reduces sort of risk for depression. It may also be sort of like a more direct that by improving sleep, we know that insomnia is one of the core symptoms of depression. So it may be just by improving insomnia, we are reducing risk for relapse. I think there's probably multiple mechanisms of action, and we'll be able to look at some of those in my currently funded R01.
Great. Yeah, I think there's just a whole set of intriguing questions from what you've learned so far. I want to make sure we open this up, and I want to see what other questions people may have. I'm going to use the Shelley Adler technique, which means we give a long wait.
Hi, this is Patty. I'm not going to get on video, but I just want to say, Jen, this is super impressive body of work, incredible. And my question really has to do with your excellent retention rate, rates that you showed, and just any sort of suggestions or lessons that you've learned that help you to get such excellent retention in this population that is being pulled in so many directions.
Yeah, that's such a great question. Thank you, Patty. Well, I think, potentially this, while they do have a lot of competing demands on their time and energy, they are highly motivated to participate in programs that may improve their health. We've also noticed sort of like this higher sense of altruism in this population. I want to contribute, even if it doesn't benefit me, the thought that it might benefit future pregnant women seems to be a common thing we're hearing from potential participants. And then I think we also have several research methods that we've refined over the last several years designed to optimize retention. So we have a multi-step screening process to ensure that the potential participants are really able to complete study procedures in sort of a timely fashion before we enroll them. We do an orientation session with participants on Zoom, where we describe in really frank detail what participating entails. We don't take a hard sell approach. We try to be very transparent about both the pros and cons of participating, so participants can make a really informed decision about whether it makes sense for them, if it's the right time for them to participate in the project. I think also having a study team, clinical research coordinators who are able to balance being really tenacious with participants, following them to get them to invite them to complete study measures, while also being really gracious, warm, and attentive to developing a relationship with these participants. It's so important, and it's really challenging to do over Zoom. I think for me, those are probably some of the key things that have helped with retention in our trials.
Oh, beautiful. Thank you.
Thanks, Jen. We have a question from Melanie Gold. The question is, any plans to add any other integrative approaches to improve sleep, like acupressure or EFT tapping or self-massage that you would consider?
Yeah, that's a really nice question. There is some research, some small pilot RCT showing that massage and like chamomile tea and sort of like lavender scent, that those sorts of things do improve sleep quality, specifically among pregnant people. So I think that's an interesting observation. I don't know that we actually have shared that information with our participants, but it's worth considering. Those sort of more like complementary approaches haven't been studied in very large trials, but I think they're just like commonly used in the pregnancy population anyway. So it would be interesting to include in our program.
Great. And Melanie has another additional question. Any plan to work with pregnant teens in your work, as this population has unique sleep-related issues compared to adult pregnant women?
Yeah, thank you for the question. As a graduate student, I did some work with pregnant and postpartum adolescents. The intervention that we studied or that we evaluated was the DBT skills program, which does have a heavy emphasis on mindfulness training and sort of cognitive and behavioral approaches. And we found it was really acceptable and associated with high satisfaction scores, and benefits for their mood. It didn't incorporate much of an impact on sleep, but I do think that would be interesting to investigate. My colleague Lauren Asarnow here at the Department of Psychiatry and Behavioral Sciences studies sleep in adolescents. So yeah, I think that would be interesting to investigate, given sort of like the profound sleep challenges that adolescents face.
All right, I think at this point, we're almost at the top of the hour. I want to wrap up and thank you, Jen, again for a great grand rounds. Thanks everyone for participating. And we will see you again for our next integrative medicine grand rounds. Thanks.